Hello and thank you to everyone, and thanks for joining us today for NCSL's 2013 Top Issues webinar series. My name is John Kuhl, Public Affairs and Media Manager at the National Conference of State Legislatures. Each year, NCSL develops a list of the most pressing and important concerns on state legislative agendas. Today we have a panel of NCSL health experts who will be discussing the issues facing states as they make decisions regarding implementation of the Federal Patient Protection and Affordable Care Act. Our experts include Dick Kauke, Martha Salazar, Laura Tobler, Amy Winterfeld, and Martha King, who will be introducing our panel. Today's webinar will include presentations by our panelists, followed by a Q&A period. To submit a question, please use the chat feature that's on the right-hand side of your screen, and we'll try to get to as many of your questions as possible. Thank you again for joining us, and with that, I'm going to turn it over to Martha. Martha King.
Hello, everyone, and welcome to NCSL's webinar, Health Reform Moving Ahead, What's Next for States? I'm Martha King, and I'm joined today by my four colleagues, Dick Kauke, Martha Salazar, Laura Tobler, and Amy Winterfeld. As most of you know, the Patient Protection and Affordable Care Act became law in March 2010. Some refer to it as PPACA, others as the ACA for Affordable Care Act, while still others refer to it as Obamacare, which became fairly common during the 2012 campaign. For the most part, we'll refer to the law as the Affordable Care Act, or ACA, during this webinar. As you all know, whatever we call it, it's very long, quite complicated, and contains numerous provisions. Today, we intend to focus on a few selected provisions of the law, provisions that states continue to address as looming deadlines approach. Two primary mechanisms in the law that are intended to expand coverage to about 32 million uninsured Americans are, first, the creation of insurance exchanges with federal tax subsidies to many Americans to make insurance plans more affordable to them, and second, the expansion of the Medicaid program to cover additional low-income people. We'll also highlight key insurance provisions in the law. States play important regulatory roles related to a variety of insurance requirements that are intended to control costs, protect consumers, and promote the use of prevention and primary care. And speaking of prevention, in addition to insurance provisions that require coverage for certain preventive services, the ACA contains many other provisions to promote prevention and wellness, including investments in public health. And of course, bending the healthcare cost curve remains a daunting challenge facing the nation and all states. On today's webinar, we'll cover the topics I just mentioned and also include some information about the health workforce challenges facing states. We'll also touch on some of the remaining challenges to the law and highlight a few of the strategies to maintain state flexibility in implementing the Affordable Care Act. Reminder that we will take a few questions at the end, and as John mentioned, you may submit a question at any time using the chat feature, which looks like a dialogue conversation bubble in the upper right-hand part of your screen. In terms of flexibility, we want to highlight that NCSL continues to work hard in Washington, D.C. to ensure a strong state voice as new ACA regulations are developed and proposed. This slide shows the co-chairs of NCSL's National Health Reform Implementation Task Force, Alabama Representative Greg Wren and New Jersey Assemblyman Herb Conaway. As you can imagine, and you all know, our NCSL members' opinions about the law run the gamut. For example, the majority of Alabama legislators oppose the federal law, while the majority in New Jersey tended to favor it, if not all of its particulars. What our members do agree on is the need to work together to promote maximum state flexibility under the federal regulations. Representative Wren and Assemblyman Conaway continue to help NCSL achieve this goal. Now let's hear from Martha Salazar about health insurance exchanges.
Thank you, Martha. If you haven't heard about health insurance exchanges yet, expect to hear a lot more about them this year. I included this slide because just like there are quite a few names floating around out there with the law itself, Health insurance exchanges are also referred to in many different ways. Whether you're reading your local newspaper, looking on healthcare.gov, or reading the exchange section in the law, you may see some of the names on your screen, and they are all referring to the same thing. For the purpose of this webinar, I will refer to them as health insurance exchanges. Either way, no matter what it's called, before January 1st, 2014, every state will have one. Ultimately, exchanges are intended to provide more affordable health insurance options to consumers and small businesses. They're a new way for those that need health insurance coverage, and everyone, with a few exceptions, will need it by 2014, to shop for health insurance, just like you can shop and compare options for a variety of things purchased online. They will not let people know the options they have, the cost of coverage, the benefits in the form of various tiers or levels of coverage, and how much they will be paying from their own pocket for health insurance for their family, depending on their annual income, the size of their family, and the benefits they hope to have covered in their plan. They're also a vehicle for administering federal subsidies and tax credits to help with paying for coverage and cost sharing. Exchange health plans must offer a minimum level of coverage, and we'll talk about these essential health benefits a little bit later. The Congressional Budget Office estimates that 25 million Americans will obtain coverage through the exchange by 2022. One of the reasons this is a hot topic this year is because of the upcoming deadlines and changes that policymakers and consumers will have to deal with. As I mentioned, every state will have an exchange by this fall. The question really becomes who will administer the exchange. Exchanges can be administered by the states, the federal government, or it can be a partnership between the states and the feds. States decide which fits their needs, budget, and citizens the best. If they do not make a decision at all, and they don't have to, the federally facilitated exchange is the default option. States are weighing these options and making their decisions even as we speak. Either way, they can change their minds later and decide to eventually run the exchange fully themselves or partner with the federal government. No matter who facilitates the exchange, the federal government will be in charge of providing the subsidies included. This slide goes into a bit more detail on what those different types of exchanges look like. In a state exchange, states are responsible for developing, operating, and managing all functions and components of the exchange. They have to meet certain criteria outlined in the law, including the rules and guidances that were released after. And states need federal approval to ensure that requirements are met. I'll go into a bit more detail on state exchanges in the next slide. In the federally facilitated exchange, the federal government runs all functions of the exchange. The question here really for states is, what will regulating insurance look like, since states are still responsible for regulating insurance? States really do know their consumers best, so how will outreach and marketing be handled? And states are still responsible for integrating the Medicaid and exchange seamless enrollment, which I'll also talk about a little bit later. In a partnership exchange, which is the third box on this slide, the state can run the plan management piece of the exchange, meaning the state will be responsible for selecting and certifying health plans that will participate, which includes defining what the standard for that certification is or will be. And or the consumer assistance function of the exchange, meaning they'll manage the navigator program. Navigators will do exactly what it sounds like they'll do. They'll help consumers navigate through all of their options. This piece also includes establishing the in-person assistance programs to enroll people in the exchange. So states can either choose to, in the partnership exchange, run either or the plan management and consumer assistance piece. The federal government still runs most of the functions of the exchange in this piece, and states still need a federal approval for this model. So there are many tasks, as you can imagine, involved in setting up a state exchange. Each major component involved and included in this diagram has many other components that go along with it. For example, if you look at the top middle box titled Authority, Structure, and Governance, the major other components involved with this are deciding if the state wants to establish the exchange as a state agency, either within an existing agency or as an independent public agency or as a nonprofit. The state also has to determine what the governing entity will look like. how many people will be on the board, who will represent that governing board, and what will the board be responsible for. States have made and continue to make many of these decisions based on what's allowed in the ACA, as well as rules and guidance that the U.S. Department of Health and Human Services and other federal agencies, such as the IRS, have provided. With that said, states are still awaiting some final rules and guidance in some areas. The federal law also requires seamless eligibility determination between the exchange, the Children's Health Insurance Program, and Medicaid, regardless of whether or not the state decides to expand Medicaid, which we'll talk about a bit more later in the presentation, or who administers the exchange in the state. States are responsible for ensuring that their systems have the capacity to make these determinations. This means, really, that anyone seeking coverage through any of these programs that you see on the screen will know if they or someone in their family may qualify for coverage through the exchange, CHIP, or Medicaid. This slide has some key dates that states have to consider or that are important for states. These key dates show when states have to make decisions and when enrollment, coverage, and federal assistance begins or ends. Deadlines recently changed. Big deadline for states was December 14, 2012. The states submitted blueprints to run state-based exchanges had to demonstrate their process is well underway to establish an exchange that will be operational by fall 2013 with coverage beginning January 2014. The timeframe is ambitious, but some states have decided to take it on nonetheless. 18 states and DC plan to run their exchange and submitted the required blueprint for HHS approval. Sorry about that. 17 of those states and the District of Columbia have received conditional approval. 7 states plan to partner with the federal government to run certain functions, although 5 have submitted blueprints for approval. So far, 2 have received conditional approval of their partnership plan. The remaining states have decided not to run an exchange, but major media outlets have reported that decisions can shift in those states. For example, Florida's governor may be reconsidering an exchange, and we'll wait to hear about that, and New Hampshire's legislature may reconsider legislation that prohibited the establishment of the exchange now that the party control has changed after November elections. As a reminder, states are not required to inform HHS if they're planning on a partnership exchange until February 15, 2013. So actually coming right up. And they can change their minds about running certain or all functions of their exchange anytime. Territories, although not listed on this map, can establish an exchange, but unlike the states, the federally facilitated exchange will not be the default option. In other words, if they decide to establish an exchange, they can, but if they don't, they won't have one. One of the biggest considerations for states in establishing exchange is, of course, the cost of it. Federal grants are available to states to assist with some of the costs, but those funds will not be available starting January 2015. States have to show that their exchange is self-sustaining once they are operational. The federal government has made various grants available to states, including planning grants, early innovator grants to develop model Medicaid and exchange IT systems, and establishment grants. Many states have decided how their exchange will be self-sustaining after federal grants expire. Some have decided to assess insurer fees. The federally facilitated exchange, for example, will fund their exchange using a 3.5% fee to carriers. As you can imagine, this all leaves lots to do by the end of this year for both states and the federal government. This presentation only provides really a brief overview. I look forward to answering some of the questions on this topic at the end. And now I'm going to pass it to my colleague, Dick Kauke, who will discuss, among other things, insurance reform provisions of the law.
Thanks, Martha, for laying out some of the major changes coming in the next 12 months. In fact, the Affordable Care Act has already made some significant changes in how tens of millions of Americans are receiving health benefits now, and how excuse me for the technical problem here. In fact, the Affordable Care Act has already made some significant changes in how tens of millions of Americans are receiving health benefits now and how health insurance will be paid for in coming years. With all the political contention and questions about the law, it's useful to step back and note four core features. First, it maintains an employer-based and private market system we've had for more than 40 years. This is how some 160 million Americans got coverage before the ACA and are receiving it as we speak. Since 2010, it combines longstanding state regulation and new federal regulation. Third, it builds on state-based guarantees for a certain kind of coverage and extends them more uniformly to many more people, both in the private market and in existing public programs. Also, there's a fourth and new feature. It requires most people to have insurance, often called the individual mandate. Here are some examples of market reforms for health insurance. The law prohibits several past practices. People with pre-existing conditions, whether cancer or asthma, can no longer be denied a health policy and cannot be charged a higher cost based on health status. Once you have coverage, your commercial insurer can't just drop you. And there no longer can be lifetime or annual limits on coverage. In addition, the law requires that insurers let young adults up to age 26 remain on their parents' insurance policy. For those ready to buy, there's guaranteed issue and guaranteed renewal of your health insurance. Your premium rates across the commercial market are subject to rate review, especially if a proposed increase is more than 10% in a year. Finally, in these examples, for seniors, the ACA added lower drug costs in the Medicare coverage gap, or donut hole. It provides reduced prices on brand name and generic drugs once a patient spends about $2,800, and about 2.8 million enrollees have benefited by this so far. Several of these features are already in place, termed early market reforms. In the next 9 months, an important decision for many states is to determine if you have or if you want the power to regulate such insurance features, or if you choose to let the federal government handle it. One of the broader insurance requirements relates to coverage mandates, termed essential health benefits in federal law. Building on what states had started, with a total of almost 2,000 separate laws, the ACA lays out 10 broad categories of coverage that must be included. These will apply to all individual and small employer policies. In 2012, HHS federal rules gave states increased flexibility and power to define and add other existing benefits called state benchmark plans. This is the list of the 10 required essential benefits in the federal law. Some are already in wide use. For example, ambulatory or outpatient services, hospitalization, prescription drugs. At the same time, some of these really expand on the more common typical policies. For example, mental health and substance abuse now is expanded to be equal or parity level services. Prevention and wellness is also expanded with no co-payments required for most services. And a new feature is services for children, including dental or vision care. This map shows examples of state decision-making. Every state was asked to select among in-state benefits, and 25 did so. Those that did not pick anything were still given a state-specific plan, not a federal one. For example, since Florida and Texas small group insurance already covers autism, that service will be included as a benchmark starting in January 2014. Some policymakers are not pleased, since this means there are variations by state boundaries and that the longer list of benefits can result in higher premiums. This debate is likely to continue on both the state and federal level. The ACA also has a requirement that most people have health coverage, commonly called the individual mandate. HHS rules on this were proposed just 5 days ago. The coverage that's acceptable includes a wide variety of existing insurance policies and programs, as well as all those offered in the exchanges, Medicaid, and others. There are also about 8 categories of individuals that are exempt from this service. For example, if available coverage is not affordable, or if they are below an income level. In the end, there is an IRS-administered shared responsibility payment, or fine. That fine starts with annual payments of $95 in 2014 and goes up to almost $700 annually by 2016. The law also affects employer-based coverage and really divides them into 2 groups. For small employers, under 50 workers, there is no requirement that they offer insurance, but there are tax incentives up to 50% next year of the employer premium cost, especially for the smaller employers with 1 to 25 employees. There are also what are called small business health option programs, a exchange specifically for those small businesses. And in addition, about half the states have plans for what are called co-op programs, where the smallest employers can get together, pool their resources, and determine what the best deal is. For large employers, it's a different situation. They are generally required to offer health insurance, and that's a new provision. Failure to do so failure to offer coverage can lead to about a $167 monthly fee or penalty per employee, but there are a variety of exceptions and steps before that applies. In a reassuring way, almost 96% of large employers over 50 workers already offer coverage, so this builds on the existing precedent. Let me turn now quickly to the question of health costs. Many of you have seen statistics. Spending on health in the United States reached $2.8 trillion in 2012. These are frightening figures, but in fact, annual increases have slowed a good deal for the past 3 years, under 4%. The name Affordable Care Act comes from the goals to move toward affordability and containing costs, looking at issues like moderating the cost of insurance, consumer and purchaser transparency, provider payment reforms, and also containing spending by federal and state governments. NCSL has a cost containment report that has details on this, and we encourage you to take a look if this is of interest. There are some specifics in the law, various methods designed to contain costs, although most of these are pilot programs. For oversight, many states can reject increases determined to be unjustified. There's also a rule that 80% of premiums go for actual health services for small and individual and small group. If they're not, there are rebates paid back to the purchaser. There are also sliding scale premiums with subsidies up to 400% of federal poverty and limits on your out-of-pocket expenses. Provider payment models are of particular focus, programs that reward results rather than services. There are such methods as accountable care organizations and medical homes, which seek to combine payments for patients, and also what's called pay for performance, based on how well doctors and hospitals reduce costs, and improve quality, and increase patient satisfaction. Also, there's a program for evidence-based medical decisions. Finally, there's more emphasis on prevention and patient safety and avoiding errors, for example, denying payment for avoidable hospital infections and readmission. The next 2 presenters will note some details on this. Speaking of which, our next speaker is Laura Tobler on Medicaid.
Thanks, Dick.
Good morning and good afternoon to all of you. I'm going to move my slide over. So as I'm sure you're all well aware, the ACA includes a number of Medicaid-related provisions. I'm going to briefly talk about those listed here with the exception of interoperability, as Martha Salazar mentioned it in her presentation, and we really don't have the time in this hour to go into details on really any of them. However, I'd be happy to send you information or discuss those if you'd like to get in touch with me. My email address is Laura, Laura.Tobler, Tobler, @ncsl.org. So let's talk about the Medicaid expansion first. If I could get my slide to move. There we go. The ACA expands Medicaid to adults aged 19 to 64 with incomes at or below 133% of federal poverty. Using the new required modified adjusted gross income calculation, which is going to be required by all Medicaid programs in determining eligibility, it brings it up to 138% of federal poverty with a 5% income disregard. Adults, especially childless adults, are a new population for many state Medicaid programs to serve, which is an important consideration when you're looking at the challenges and getting ready for an expansion. The states will receive 100% FMAP, that's the federal financial participation rate, for the newly eligible population from 2014 through 2016, and that declines gradually, reaching and staying at 90% in 2020. The Medicaid expansion was challenged, and the Supreme Court did consider that challenge. They did not change the Medicaid provision in the law, but their ruling effectively allowed states to opt out. So right now, the Medicaid expansion is an option for states to choose. Since the Supreme Court's ruling, CMS has answered several questions that states have been seeking answers for, and I'm just going to go through some of those recent answers. So the first is there a deadline for expanding Medicaid? CMS has said no. States don't have to roll it out on January 2014. They can choose to expand at a time that is more convenient for them. However, the federal financial participation timeline remains as it is outlined in the law. So 2014 to 2016 is the 100% match. If a state expands Medicaid after that time, they receive the lesser or scaled down amount based on that timetable. I just wanted to make that clear. Can states partially expand Medicaid? This was something that I know many states had conversations about, perhaps just expanding Medicaid up to 100% and then allowing the subsidies in the exchange to cover those that were over 100%. The answer to that was no. The law states that the expansion has to be up to 133%, so no partial expansions. Once expanded, can states roll back? The answer is yes. If it's not working for your state, you can unexpand, or so to say. Will there be flexibility in cost sharing and benefit packages? A January 2013 proposed rule indicates that CMS is going to look at additional flexibility in cost sharing and benefit design for states that are expanding Medicaid. There still are lots and lots of remaining questions. I've just posed a few of them there for you to look at. I'm sure you have your own questions. I'd actually be interested in knowing what those are if you want to shoot me an email. How many people who are currently eligible but not enrolled will actually seek out coverage and end up on Medicaid is a really big question for the states because it hits home right there in the budget. These are the folks that are currently eligible but not enrolled and therefore will not be eligible for the enhanced federal financial participation. So how many of those folks will actually seek out coverage in 2014 is a really important question and one that's very difficult to answer. In some states, this number is large, meaning that the resulting costs will be large. However, many of these individuals are also low income and may not be subject to the financial penalties that Dick just mentioned. So maybe they will not be as quick to seek out coverage. So this is something that I know states are pondering. I'm not going to go through the other questions. I just wanted to put them out there to say that there are still lots and lots of questions that our states are asking about the Medicaid expansion. And speaking of the expansion, I know everyone's talking about which states will and which states won't. This is my rumor has it slide. So in other words, the states are listed here as either expanding, leaning towards expanding, leaning against expansion, based on popular press or based on press releases from a governor's office or from a political leader in the state. So this is what the lay of the land looks like right now. This is a moving target, and probably the most important thing about this slide is that no one really knows yet in most states how this is going to fall out. So just wanted to let you know that there's definitely talk, though, and movement. So check back with us. So far this session, we are seeing bills. We're seeing bills that to expand Medicaid, to require the legislature to approve an expansion, to urge the governor to expand, to reject an expansion, and others. Some of those others are related to financing, like where the state will get the money to pay for the expansion. Moving on, leaving the expansion behind, I want to talk a little bit about some of the other provisions, the first being fraud and abuse. Many new provisions related to Medicaid program integrity were included in the Affordable Care Act. States are interested in shoring up their Medicaid programs with an emphasis on preventing fraud and abuse instead of chasing the money once it's been spent inappropriately. These are just the major components of the Affordable Care Act that give states more authority related to fraud and abuse, and that also allow states to partner with CMS on fraud and abuse. So the individual in our office who works on this is Megan Kamlasi, and her email is her name, megan.kamlasi@ncsl.org, and she can help you with any questions you might have on this topic. Let's move on to dually eligible. This is also a very significant component of the Affordable Care Act's Medicaid provisions, and has also been a very, very important topic for states to get involved in. And I'm going to go through some of the details why. The ACA created new opportunities for state Medicaid programs to integrate and coordinate care for people who are dually eligible for Medicare and Medicaid. These are folks that are elderly or people with disabilities qualify for both programs. The law created a new office within CMS called the Medicare-Medicaid Coordination Office to work with states to align the care and financing for this group. It also increased states' access to Medicare data, which helps with that integration. 15 states were approved for demos to integrate care for dual eligible individuals, and these are the states that are going to do the experiment that will help other states learn what works and what doesn't work. So why the focus on dually eligibles? Well, it's because there's definitely room for improvement. Currently, their care is fragmented and it lacks a single point of accountability. If you look at this slide, Medicare, Medicaid enrollees represent 15% of Medicaid enrollees, but they represent 39% of Medicaid spending. So definitely an area where because there's room for improvement, there can be a significant increase in quality and a reduction in cost if we can do this right. So in addition to the 15 states, there's also 26 states that submitted proposals to work with CMS on demonstration projects that test new payment and delivery models of care to improve the quality and hopefully reduce the cost of care for those that are dually eligible. This map shows you that 20 states are pursuing a capitated or managed care model. 6 states are proposing managed fee-for-service models. And finally, the last thing to say about this slide is don't count your savings yet. We need data, we need results, we need to know how this is going to work before you can forecast your savings. PPACA also has provisions to promote the use of home and community-based services. Currently, every state uses home and community-based services in some capacity. However, in 2009, the latest figures, nursing facility expenditures almost doubled home and community-based service expenditures nationally. There are some states, though, that have taken home and community-based services further than others. States where the financial balance is tipping more towards home and community-based services are Vermont, Minnesota, New Mexico, Arizona, Alaska, Oregon, and Washington. All of these states spent 60% or more of their long-term services and support dollars on home and community-based services in 2009. So we're definitely moving in that direction, and the research shows that the beneficiaries want states to be moving in that direction. People want to stay in their homes. So that concludes my comments on Medicaid. You have my email address. Please get in touch with me if you have questions. And now I'm going to turn it over to Amy Winterfeld.
Thank you, Laura. In addition to ensuring that more Americans have health insurance to access medical care when needed, another aim of the Affordable Care Act is to bring about not only health care reform, but health reform. That is, to shift the focus of the U.S. health system from sick care to keeping people healthy. Currently, about 95% of U.S. health expenditures go to treating diseases and injuries after they occur, and only 5% is spent on public health, which focuses more on prevention and keeping our entire population well. And out of the $2.8 trillion that the U.S. spends on health care each year, people with chronic conditions account for about 85% of expenditures. Yet these costly chronic diseases, which also account for between 60 and 70% of premature deaths, can often be prevented, or their onset postponed. According to the Centers for Disease Control and Prevention, 4 modifiable health risk behaviors, lack of physical activity, poor nutrition, tobacco use, and excessive alcohol consumption, are responsible for much of the illness, suffering, and early death related to chronic disease. To help rein in the high costs of chronic diseases and move the country from a culture of sick care to a culture of prevention and wellness, the ACA addresses these 4 areas: modernizing disease prevention and public health, increasing access to clinical preventive services, creating healthier communities, and support for prevention and public health innovation. Among the costs that may be reduced by an emphasis on prevention are these obesity and tobacco use-related costs, and it's taxpayers who foot the bill for Medicare and Medicaid. One ACA approach to modernizing disease prevention and improving public health systems is the creation of a National Prevention Council under the direction of the U.S. Surgeon General. The Council created a national prevention strategy and an action plan that aims to integrate prevention efforts across 17 federal departments. Highlights of the plan include increased tobacco-free environments and improving access to affordable, healthy food to help prevent obesity, type 2 diabetes, and heart disease. Massachusetts and Rhode Island are working on state councils modeled after the National Prevention Council. The National Prevention Strategy provides a roadmap to move the health system from focusing on sickness to emphasizing prevention and wellness. To increase the number of Americans who are healthy at every stage of life, the approach identifies 4 strategic directions and 7 targeted priorities. These are the strategic directions: healthy and safe community environments, clinical and community preventive services, empowered people, and elimination of health disparities. Here's a list of the 7 priority areas, which include tobacco-free living, preventing drug abuse and excessive alcohol use, healthy eating policies, such as incentives to improve access to healthy, fresh food, active living, such as complete street policies that facilitate physical activity with sidewalks and bicycle lanes, injury and violence-free living, reproductive and sexual health, such as evidence-based programs to prevent teen pregnancy, and mental and emotional well-being. ACA also established a Prevention and Public Health Fund, the first such dedicated federal prevention funding stream. Originally, the fund appropriated $12.5 billion over a 10-year span to prevent chronic illness and provide for community-based prevention efforts that are evaluated for effectiveness. More than $2 billion has been distributed from the fund since 2010, including direct grants to states and communities. But in 2012, Congress tapped some of this prevention funding to pay for other programs and budget shortfalls. ACA also expands the efforts of the U.S. Preventive Services Task Force and the U.S. Community Preventive Services Task Force and improves coordination between the two in order to review the evidence of effectiveness of individual clinical health care services like cancer screening and of population-based prevention efforts such as creating smoke-free public places. ACA boosts clinical preventive services in a number of ways. In new health plans, insurers must cover preventive efforts that have been proven effective, such as immunization, colorectal cancer screening, and regular checkups that measure weight, blood pressure, and cholesterol, all without a copay. Medicaid patients may now be offered incentives for weight loss, lowering cholesterol, improving blood pressure, preventing diabetes, and stopping tobacco use. And ACA has funded grants for school-based health centers that provide access to health care for youth, many of whom otherwise would not be served. Here's a list of preventive services for adults under the ACA. And additional preventive services are covered for women, children, and Medicare beneficiaries. ACA also introduced nationwide requirements for providing information such as calories for standard menu items offered by chain restaurants with more than 20 locations nationwide, and for offering break time and a private location other than a bathroom for nursing mothers to express breast milk. The Act has also funded community transformation grants administered by the Centers for Disease Control and Prevention that are expected to improve Americans' health through community-determined efforts, such as reducing tobacco use and exposure, encouraging physical activity through transportation planning, and supporting healthy eating, for example, through farmers markets. In 2011, CDC awarded $103 million to 61 state and local government agencies, tribes, and territories. And in 2012, approximately $70 million was awarded in community transformation grants to 40 smaller communities nationwide with fewer than 500,000 people. This map provides an overview of the locations of the 61 CTG grants awarded in 36 states and to 1 territory and 7 tribal communities in 2011. Workplace wellness programs are also encouraged by ACA provisions that give employers flexibility to offer employee financial incentives to get and stay healthy. Beginning in 2014, these can include reduced health insurance premiums or copays, gym membership, weight management classes, or tobacco cessation programs. The Childhood Obesity Demonstration Project funded by the ACA was launched in September 2011 as a 4-year project with community health worker outreach and research support from the University of Texas Health Sciences Center at Houston, San Diego State University, and the Massachusetts Department of Public Health. Demonstration project results will be disseminated nationwide in September 2015. Now I'm going to turn the floor back over to my colleague, Laura Tobler.
So we're going to talk really briefly about workforce. And some of you that are sitting out there in rural and frontier states are probably thinking that briefly is really not enough time to talk about an issue that really does occupy a lot of your policy discussion. But I have 4 minutes to talk to you about a topic that's extremely important and complex. So my purpose today is to reinforce that health workforce issues need to be on the policy agenda. And for those folks that are in rural and frontier states, I know these issues are probably really already top on your priority list. So this slide is just to validate that states have been working on these issues for many, many years, and health workforce shortages already exist, but will be magnified by the future expansion in public and private coverage, and then taking into consideration the fact that we have an aging workforce, we have an aging population, which when we age, we require more care. We have a population that has more and more chronic diseases requiring more care. We have workforce maldistribution, so we have overages of physicians in certain areas and then severe shortages in others. And then the workforce shortages will be magnified if we maintain traditional methods of delivering care. The ACA included many provisions to address primary care workforce shortages through research and collaboration by creating the National Workforce Commission, through grants focused on training more primary care workers, through expansions of existing programs such as the health centers and the National Health Service Corps, and through payment reform such as increasing primary care reimbursement rates, encouraging the use of accountable care organizations, and encouraging the use of health homes. Some of you know them as medical homes. So my next slide is just a way of thinking about workforce shortages, and I borrowed this from Keith Mueller, who did an excellent presentation at NCSL's Legislative Summit in 2010, right after the law had passed. And he says there's 3 fundamental approaches to addressing workforce shortages: building the supply, reforming the delivery model, and improving the public's health. And one size does not fit all states, and certainly one approach is not going to be enough to solve the workforce problems, access to workforce problems that we have in the states. So looking at all 3 is probably the most comprehensive way to look at it. So building the supply would be looking at recruitment and retention programs, incentive programs for providers, pipeline programs to build the providers from high school through college or community college, educational reform, allowing primary care providers to practice to the maximum level of their education. And I know a lot of states are working on that issue related to scope of practice. Since January 2011, there have been 2,319 scope of practice bills proposed in 53 states, territories, and DC. So a very active area for legislators. Reforming the delivery model would be looking at using technology like telemedicine, telepsychiatry, looking at retail clinics, looking at medical homes, looking at health homes as ways to reform the delivery model, and then improving the public's health. If we can focus efforts on improving the incidence of chronic disease, reducing the incidence of chronic disease, you'll reduce the demand for service. With that, I'm going to conclude my workforce comments and just encourage you to get in touch with me if you're working on a bill that you'd like to get research or you would just like to discuss, or you'd like me to get you in touch with another state that might have already tried that strategy. I would be happy to do that. So be in touch with me on this issue. Now I'm going to turn it back over to Dick, and he's going to talk to us about challenges and alternatives.
Thank you, Laura. It's very widely known that the ACA was challenged in the federal courts. Within hours of signing, there were lawsuits filed, ultimately 24 of them, with lower courts differing about its constitutionality. The final result is also fairly well known. The United States Supreme Court upheld all but one provision. As Laura has indicated, the Medicaid expansion cannot be mandatory with a financial penalty. It's now an option. All other provisions, including the individual mandate, were declared constitutional. From the start, state legislatures were an early testing ground for support and opposition. At least 45 states had opposition bills considered. By last November, 20 states had passed laws and constitutional amendments opposing mandates for employers to offer coverage and individuals to purchase insurance. Also, most of these bar state agency enforcement of the penalties. This state map shows states that passed such measures. Now that the individual mandate language was upheld, the federal law does not actually require states to play any direct role in these mandates. No state has to collect any fees or penalties from individuals or from employers. So these state statutes and amendments have less effect, although some do bar state agency implementation generally. Since the Supreme Court decision, there have been a couple of new court challenges, and two specific ones looking at a focus of opposition. And both are actually about regulation and not the statute itself. The first, much discussed one, is a requirement for employers to offer coverage that includes fully paid contraception coverage. Business owners, employers, religious leaders have all objected on grounds of religious freedom with numerous lawsuits filed. There's a delay agreed to by HHS, and new exemption proposals were announced just last Friday. Lower courts have granted a couple of temporary delays or injunctions specific to paying for birth control, and there's speculation that this issue could end up at the Supreme Court. Second, there's a question of tax law interpretation, really a technical matter, but one that has some implications. And it's about whether the premium subsidies that are guaranteed in the law for low and moderate income people apply only to those in a state-run exchange, or whether it also applies to federal health exchanges. It's too early to say exactly where these two issues will end up. There are, in fact, other alternatives and that may affect the way the law works. One of the provisions already in the law is what's termed a waiver for state innovation, Section 1332, that allows states to seek an alternative approach rather than an individual mandate or rather than exchanges. And those can be filed by states as of 2017, and some indication that they may be accepted sooner than that. There's also individual states that are interested in what's called cross-state buying of insurance with an aim of having fewer mandates. And recently, 7 states have approved joining what are called interstate health compacts. These are aimed at allowing states to join together to create state programs to replace federal law. However, as passed so far, these compacts do not actually block ACA implementation, and they're not yet binding. They will require congressional approval. Finally, there's often concern about funding. Will there be enough federal funds, and will state budgets be expected to cover more costs? With that, I'd like to turn it back to Martha King.
Great, thank you everyone. Clearly many questions remain about implementing the ACA. Some are listed here, such as will states change their minds about the insurance exchanges? If you expand Medicaid, what will it cost? We at NCSL are committed to tracking state activities and reporting to you about things as they evolve. So check off and back on our website. Now we have a few minutes for questions from you all. Also, check out our website and contact us if we're not able to get to your question. As Laura has indicated to you, our individual email is firstname.lastname@ncsl.org. Or if you're not sure who a question will go to, please look at the email here, health info@ncsl.org, and your questions will be distributed. We do have a first question here that says, early in the presentation, it was mentioned that states have the ability to regulate certain benefits. Can you please expand on that? I'll turn that over to Dick.
Thanks. States have actually enacted a variety of specific laws, and NCSL has listed these on one of our reports, which is on our website as Go 19948 if you enter that at the top, or you can get to it from the health reform website listed. Another report released last week suggested that only a shorter list of states have had enough direct legal authority enacted. We'd be happy to talk to you individually about what your state has so far and what else is an option.
Okay, the next one is for, let me throw it to Laura Tolber. What are the top educational training efforts that institutions of higher education need to focus on due to the ACA?
So I think that some of the things that have been happening in this area actually started prior to the ACA passing, and states have been working on policies to even out the primary care workforce for years. And so in the education and training, looking at ways to streamline the educational pathway for physician assistants who are physician extenders and can help with primary care access, looking at ways to encourage advanced practice nurses to go into teaching so that there will be the available teachers to teach the students who want to be taught, because that can be a bottleneck. Looking at ways to reform the educational curriculum so that there's more of an emphasis on health home and medical home and ACO type practice, where it's practiced by group, and that's something that I know is happening out there. So these are just a few. There's been a lot of really good work in this area, and whoever is the asker of this question, if you want to shoot me an email, I can get you in touch with some of that research that is being done.
Laura, Amy, let me give this one to you. What are some state policy options to support healthy communities?
One option is smoke-free policies. Those have been rated as having strong evidence of effectiveness by the Community Preventive Services Task Force, and then some of the others, as I mentioned, are incentives for access to healthy foods, through farmers markets, and how people design communities, providing infrastructure like sidewalks and bicycle paths that enable people to be physically active.
Great, thank you. And one more here. But before I do that, let me let you know that those of you who pre-registered and are on the call right now should have received an email with the slides attached this morning, if you didn't notice that. And as soon as they are posted on NCSL's website, we'll send you an email that indicates where you can find those slides with the audio. And now for Martha Salazar, have you seen legislation during the 2013 session so far about establishing state insurance exchanges?
Yeah, that's a great question. States are considering establishing state-based exchanges still, because as I mentioned earlier, they do have the option to do so. So of the 18 states that have decided to submit a blueprint establishing a state-based exchange, 10 of those and the District of Columbia did establish legislation prior to, enacted legislation prior to submitting those blueprints, approving the legislature, with the legislature approving those state exchanges. And so far, in 2013, 10 states, as of early last week, have are considering legislation to establish an exchange. In addition, there are some states that are considering repealing or prohibiting health insurance exchanges in some way, and then other bills so far, though, with other parts of the exchange, such as the role of navigators in selecting insurers. I encourage anyone to go to NCSL's Legislative Tracking Database webpage available on the health reform website listed on the screen and check out some of the things that we have tracking for 2013. Other topics, including insurance reform and essential health benefits, are included in that legislative tracking database.
Great, thank you, Martha. And we do have time for just one more that came in. I'll send this one to Dick. For the health insurance market reforms, what do states need to examine to know if they have the regulatory authority that they want?
That's similar to the first question that you asked about what states need to do to expand their regulatory authority. As I indicated, there are already numerous states that have laws that have been passed relating to the market reforms, but it's worth a closer look, and we'd be happy to talk with you individually about where your state stands. And let me give my email for that purpose. Dick, dick.pauthi@ncsl.org.
Great, thank you. Thank you so much for participating. This concludes our webinar. We really appreciate your participation in this, and do let us know if we can be of any other assistance.